Good morning, everyone. I'm Rebecca Vickers, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled The Relationship Between Suicide and Alcohol Misuse with Dale Robertson. This webinar is being made available through a collaboration of the Florida Department of Children and Families, Office of Substance Abuse and Mental Health, and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me, the host, by using the chat panel. The button to open the panel is usually located on the lower right side of your monitor. Please use the chat panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Please note you will be unable to see other participants' chats. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options are posted in the chat panel. If you continue to experience poor audio through your computer, try rejoining the webinar by using the call-in telephone option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on FADAA's website within 30 business days. To access the recording and PowerPoint, go to www.fadaa.org, then to our resource center, and then onto our training library. FADAA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credits for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on FADAA's website. You will need to first log in or register to your account to complete the evaluation. Information you provide FADAA as a part of registering remains confidential. Statements of credit will be posted within 30 business days after the evaluation closes in individual professional development. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Do note that the evaluation will close midnight on Wednesday, February 16th. Up to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license numbers for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside of the state of Florida, you do not need to provide a certification number when you register with our site. Please note that WebEx monitors arrivals and departures of attendees and provides a report upon completion of the event. We are not permitted to provide a certificate of attendance if you do not attend the entire webinar, and we are not permitted to provide partial credit. Dale Robertson, a University of Chicago grad, has been a substance use therapist for the Recovering with Pride program at Howard Brown Health Counseling Center since October 2020. His previous professional experience includes the manager of outpatient services at Haymarket Center for 2 years. Dale's trauma-responsive clinical applications include dialectical behavioral therapy, substance use management, harm reduction, and motivational interviewing, to name a few. In addition to his work at Howard Brown Health Counseling Center, Dale is a facilitator at Haymarket Center's 6-month CADC Addiction Counseling Preparatory Course. In recent years, teaching and providing in-service multicultural diversity and awareness, racialized trauma, and LGBTQIA+ clinical competency trainings have contributed to his expanding skill set. And now I'd like to welcome today's presenter, Dale Robertson. I will turn the presentation over to you.
Good morning, everyone. Thank you so much for being here and spending this couple hours with us. And thank you so much, Rebecca, for that intro. So yes, my name is Dale. Also, my pronouns are he, him, and his. And this is the relationship between suicide and alcohol use. So our objectives for today, we're going to have a discussion of research on associations of suicidal behavior, including suicide and suicide attempt, with acute use of alcohol and alcohol use disorder. 2, we're going to unpack the complexity of suicide with its several psychological, social, biological, cultural, and environmental factors. And we're going to discuss potential risk reduction, prevention, and clinical strategies we can employ to reduce this very public health concern. So why are we here? So this presentation summarizes the relationship between alcohol use and suicide, provides behavioral treatment and prevention professionals with information on the scope of the problem, an understanding of traditional barriers to collaboration and current programming, and ways to work on alcohol misuse and suicide prevention strategies. So when we start thinking about the link between alcohol use and suicide, suicide does claim more than 800,000 lives each year worldwide, and is the second leading cause of death among people ages 15 to 29. Now, for every suicide, approximately, at least 20 non-lethal suicide attempts have occurred primarily by attempted overdose. Now, these attempts are the leading cause of hospitalizations from injury and a potential risk factor for eventual suicide. Alcohol use may confer risk for these outcomes proximally through acute use of alcohol, AUA, which is an acronym we will be using throughout this presentation, which has been defined as the use of alcohol within 3 hours or within 6 hours of suicidal behavior, or any blood alcohol concentration, BAC, in an individual who attempted suicide or died by suicide. Now, looking at some of the current information in Florida, since that's where this is based from, in 2019, suicide was the 8th leading cause of death for all Floridians. As the second leading cause of death for people ages 25 to 34, although the death rate by unintentional injury is 4 times higher than deaths by suicide, suicide does remain the second leading cause of death, followed by homicide, cancer, and heart disease. Suicide was the third leading cause of death for people ages 15 to 24. Suicide is the fourth leading cause of death for people ages 5 to 14, 35 to 44, and 45 to 54. And suicide was also the 8th leading cause of death for people ages 55 through 64. And that comes directly from the Florida Vital Statistics Annual Report that was released in 2019. So in the 2019 Florida Youth Risk Behavior Survey results are as follows. 33.7% felt sad or hopeless for 2 or more weeks in a row. 15.8% purposefully hurt themselves without wanting to die. 16.8% seriously considered attempting suicide. 11.8% made a plan to attempt suicide. And 7.9% have attempted suicide. So we can definitely see how certain aspects of major depressive disorder really play a key role into this, particularly with the first statistic, which is 33.7% felt sad or hopeless for 2 or more weeks in a row. Also in 2019, 3,427 Floridians died by suicide, which does represent a 3.5% decrease from the number of deaths in 2018. Over half of suicide deaths in 2019 involved a firearm. More on that later for sure. For non-fatal intentional self-harm injuries, there were a total of 8,370 hospitalizations which occurred in Florida in 2019. Furthermore, the emergency department had 12,514 visits that were related to self-harm injuries. And of note, intentional self-harm includes incidents with or without the intent to die. Therefore, not all self-harm injuries represent suicide attempts. And if we think about different types of self-harm, there's cutting, burning, pinching, hair pulling, so on and so forth, and they don't always represent suicide attempts. Nevertheless, non-suicidal self-injury may incur additional risk for future suicide attempts and potential death. So while there isn't always a link between self-injury and suicide, as there has been for quite some time, an escalation of these could lead to future more riskier attempts. So looking at this first chart, and again, this is based in of data from Florida. So this chart depicts a slight overall increase in the age-adjusted suicide rates, death rate across genders and age groups across the decade. As depicted in this particular chart, white males continue to die by suicide at a rate of 29.7 per 100,000, followed by Black males at 10.0 per 100,000, white females 8.6 per 100,000 in a population, and Black females 2 per 100,000. So as you can see, there is definitely an overwhelming number of white male suicides. So as we will be talking about later, that is definitely a high-risk group. And we can see that the numbers have remained relatively steady between 2010 and 2019, though a slight uptick for white males in 2018. Chart number 2, what's of note is that it depicts 722 individuals aged 55 to 64 years old have died by suicide in 2019. The age group with the second most deaths was 45 to 54, followed by those aged 25 to 34, right? And as we'll also see, this group tends to be higher with white males, right? But we do see an interesting progression of this as people get older, but it tends to peak around 55 to 64 and does start to decline as we get further further along into the life cycle, but still significant. So this graph really talks about the external causes of death by suicide. And as I said, we're going to be talking about firearms. Here, firearm deaths are overwhelming, particularly in Florida. So here you can see that firearms represent the largest percentage, with about 53% of deaths, followed by hanging, suffocation, drugs and biological substances, other methods, and jumping from a high place. Right, so firearms continue to be the most commonly used method in suicide deaths. So it's important that when we are talking about alcohol use, that we do get a refresher about symptoms of alcohol intoxication. And this comes directly from the DSM-5. Right? So there's 4 criterion here to consider. One, or A, really is the recent ingestion of alcohol. Right? For criterion B, there has to be clinically significant problematic behavioral or psychological changes, that being, for example, inappropriate sexual or aggressive behavior, mood lability, impaired judgment that has developed during or shortly after alcohol ingestion, right? So these necessarily can't be present beforehand in order for it to meet the criteria for alcohol intoxication. Right? For criterion C, it has to be one or more of the following signs or symptoms developed during or shortly after alcohol use. Slurred speech, incoordination, it's physical incoordination, an unsteady gait, nystagmus, which is the rapid involuntary movement of the eyes. And when police does stop someone and does a sobriety test, often they would shine a little flashlight in their eyes and move it from the left to the right. And if there is a rapid involuntary movement of the eyes, that could be a key factor that the person is intoxicated with alcohol. E here is impairment in attention or memory, a stupor or a coma. And for criterion D, these signs or symptoms are not attributable to another medical condition and are not better explained by another mental disorder, including intoxication with another substance. Right, so here's an opportunity for us to be able to rule out any other potential substances or any other mental health issues, so that way we can really focus in on alcohol intoxication. And the symptoms of alcohol withdrawal, again, taken directly from the DSM-5, criterion A, sensation of or reduction in alcohol use that has been heavy or prolonged, right? So there has to be a decrease in the alcohol use. Criterion B is 2 or more of the following developing within several hours to a few days after cessation or reduction in alcohol use. There's autonomic hyperactivity, which is sweating or a pulse rate that is greater than 100 beats per minute. Increased hand tremor, insomnia, nausea or vomiting, transient visual, tactile, or auditory hallucinations or illusions, psychomotor agitation, anxiety, and generalized tonic-clonic seizures. Criterion C is that these signs and symptoms in criterion B cause clinically significant distress or impairment in social, occupation, or other important areas of functioning. And D is that these signs or symptoms are not attributable to another medical condition and are not better explained by another mental disorder, including intoxication or withdrawal from another substance. So the diagnostic criteria for alcohol use disorder, what we have noticed with the revision of DSM-5 is that there have been an increased number of criteria. So here there are 11. So alcohol is taken in larger amounts or over a longer period of time that was intended. A persistent desire or unsuccessful efforts to cut down or control their use. A great deal of time is spent in activities necessary to obtain alcohol, use alcohol, or recover from its effects. Cravings. Recurrent alcohol use resulting in the failure to fulfill major role obligations at school, work, or home. Continued alcohol use despite persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of alcohol. Important social, occupational, or recreational activities are given up or reduced in favor of alcohol use or because of alcohol use. Recurrent alcohol use in situations in which it is physically hazardous. The alcohol use is continued despite knowledge of having a persistent or recurrent physical or psychological problem that is likely to have been caused or exacerbated by alcohol. And of course, increased tolerance and withdrawal symptoms. And in order for us to diagnose the severity of an alcohol use disorder, for mild, 2 to 3 of these criteria have to be met. For moderate, 4 to 5 criteria met. And for severe, it's 6 and over. So alcohol's contribution to suicidality. Alcohol use disorder is the second most commonly identified mental disorder among suicide decedents worldwide, and the most common is mood disorder, which suggests that alcohol use disorder is a major contributor to population level rates of suicide. Key reasons that AUD is a major risk factor for suicide include its role in contributing to depressive episodes that are substance-induced, disruptions in interpersonal relationships, for example, breakups or just relationship turmoil, and repeated exposure to alcohol intoxication. The CDC and prevention define suicide as death caused by self-inflicted injuries with the intention of dying from the results of such actions. The key word here is with the intention of dying, because that is what separates it from self-injury, right? Now, sometimes an act of self-injury could unintentionally lead to a suicide attempt, right? But again, there's the intention part of it that is really what defines suicide. Compared with the general population, individuals with alcohol dependence and persons who use drugs have a 10 to 14 times greater risk of death by suicide, respectively, and approximately 22% of deaths by suicide have involved alcohol intoxication. And to give a little bit of contrast, one study has found that opiates were present in 20% of suicidal deaths, so actually not that much below. Marijuana in 10.2%, cocaine in 4.6%, and amphetamines in 3.4%, just to give you a little bit of an idea how alcohol ranks across other commonly used substances. Suicide is highest among patients living with bipolar disorder and unipolar affective disorder, followed by schizophrenia and anxiety disorders. Men living with comorbid depression and alcohol use have the highest long-term suicide risk, that being 16.2%. And the prevalence of lifetime suicide attempts among patients with alcohol use disorder and bipolar disorder is reported to be between 21% and 42%. Similarly, patients with bipolar disorder and comorbid substance use disorder have earlier onset mood symptoms. They have higher rates of anxiety disorders, more suicide attempts, and more frequent hospitalizations than patients with bipolar disorder alone. So I want to take this moment and ask Rebecca, are there any questions or anything in the chats?
I don't see anything, Dale. I think Rebecca has stepped away for a second.
Okay, okay. I just want to check. Thank you, Eric. All right, we will move on. So AUA and suicidal behavior by firearm. The data shows, as we discussed a little bit earlier, that alcohol intoxication is most commonly present in suicide by firearm among young adult and middle-aged men. And such data provide a strong empirical rationale for the common clinical practice of holding intoxicated suicidal patients in emergency settings to allow for a drop in BAC before assessing suicidal risk and considering discharge, right? And I gotta say that last bullet point was something that I didn't really realize before doing this research, but that makes a heck of a lot of sense now that I think about, just the dangers of and the prevalence of firearm deaths. Right? So, acute stabilization. Clinical recommendations suggest that inpatient care for individuals with alcohol misuse who present with suicidal plans or intent, preferably in a dual diagnosis facility, that being a treatment setting with alcohol use disorder and substance use disorder in general, and comorbid mental illness. And evidence suggests that suicidal individuals with comorbid AUD significantly benefit from inpatient treatment relative to outpatient settings. And additionally, acutely intoxicated individuals with suicidal urges appear to stabilize quickly in inpatient care. However, relapse and suicidal behavior following discharge remain significant concerns. So in addition to that, transferring to another inpatient setting following acute stabilization, it may decrease the risk of post-discharge suicidal attempts, and longer treatment courses, whether inpatient or outpatient, may lower the post-treatment risk of suicidal behavior. And notably, impulsive suicide attempts may be a strong indicator of relapse risk after their discharge. So individuals with alcohol dependence who are hospitalized for an impulsive suicide attempt have higher rates of post-discharge relapse and often relapse faster than those without an impulsive attempt. And this often lends support to the clinical utility of targeting suicidality, and alcohol misuse simultaneously in the acute stages of treatment. So the mechanisms responsible for alcohol's ability to increase the proximal risk for suicidal behavior include alcohol's ability to, one, increase psychological distress, increase aggressiveness, propel suicidal ideation into action through suicide-specific alcohol expectancies. Alcohol may supply the motivation to complete the action. The user may believe that alcohol will assist in completing suicide painlessly. And four, constricts cognition, which does impair the generation and implementation of alternative coping strategies. And thinking about risk assessment and management, the goal of any intervention involved with alcohol use and suicide is to treat the acute modifiable risk factors and to continuously endure the individual's safety. Individuals at high risk for suicide should be hospitalized as a precaution, and detoxification treatment should be started immediately. Subsequently, it is crucial to make the individual aware of the process of rehabilitation. Thinking about at-risk population for suicides. So the following populations are known to have an increased risk for suicidal behaviors, just in alphabetical order, not in order of severity, but American Indians and Alaskan Natives, individuals that are bereaved by suicide, individuals in justice and child welfare settings, individuals who engage in non-suicidal self-injury, individuals who have attempted suicide, individuals with medical conditions, especially more chronic medical conditions, individuals with mental and or substance use disorders, LGBTQIA+ individuals, members of the armed forces and veterans, men in midlife, and older men. And the warning signs of substance misuse. This is not an exhaustive list, but these are some things that we can observe. Having the smell of alcohol in your breath, slurred speech or stutters, and is incoherent, difficulty maintaining eye contact, tremors, exhibiting impaired coordination or unsteady gait, experiencing wide mood swings, lots of highs, lots of lows, appears fearful or anxious, having panic attacks, appears impatient, agitated, or irritable, is increasingly angry or defiant, behaves in an impulsive or inappropriate manner, denies, lies, or covers up, takes unnecessary risks or acts in a reckless manner, misses interviews, appointments, or meetings, or arrives intoxicated, appears distracted or disoriented, difficulty concentrating, focusing, or attending to a task, makes inappropriate or unreasonable choices, difficulty making decisions, blackouts, needs directions repeated frequently, and has difficulty recalling any known details. Warning signs of suicide, talking about wanting to die or to kill oneself, looking for a way to kill oneself, such as searching online or buying a gun, talking about feeling hopeless or having no reason to live, talking about feeling trapped or in unbearable pain. You know, that can be emotional pain, but it can also be physical pain too. Talking about being a burden to others, increasing the use of alcohol or drugs, acting anxious or agitated, behaving recklessly, sleeping too much or too little, withdrawing or feeling isolated, showing rage or talking about seeking revenge, displaying extreme mood swings, losing interest in things, or losing the ability to experience pleasure. Now, what you'll notice is that a lot of these do tie into symptoms of major depressive disorder, right? And sometimes any one of these in isolation, aside from, of course, talking about wanting to die or kill oneself, or looking for a way to kill oneself, you know, may not in and of itself indicate suicidality, but it's something to keep in mind, right? It's something that should perk up our ears as clinicians, and then we explore more. You know, we ask relevant questions, right? If we don't already have the context, we look for the context. We look for the context clues, right? This is the importance of assessing for suicidality in a way to where we can evoke as much information as possible, so that way we can intervene. Okay.
Hey Dale, this is Rebecca. We have a couple questions in the chat panel. Is this a good time for me to read them to you?
Absolutely, go right ahead.
Okay, great. We have a question that says, how do you differentiate between self-harm behaviors and suicidal ideation? Ideation, sorry everyone. And when do you know to transfer to a higher level of care when working with clients? I imagine self-harm behaviors can become increasingly more dangerous if it is occurring while under the influence of substances.
Sure, yeah, that's a great question. So how do I differentiate between self-harm and suicide ideation, and when do I know when to transfer to a higher level of care, specifically if they are under the influence? Well, the first thing that I want to say is if alcohol use or any substance use is also contributing to these suicidal thoughts, what I would like to do is try to address the substance use first, right? So if, for example, if alcohol use is prevalent in this individual's life, and that does lead to the suicidal ideations or self-harm behaviors, I would address the substance use first. And if we're able to get the individual, say, into detox, and then assess after that, then we can see. And with describing the difference between self-harm and suicidal ideation, you know, so self-harm behaviors, as I said earlier, often get conflated with suicidal behavior. when in actuality, a lot of self-harm behaviors come from a need to release any emotional pain or to even feel something, right? I would also want to assess what is the function of the self-harm behaviors, right? Self-harm behaviors could also be as simple as someone wearing a rubber band over around their wrist, and they just snap their rubber band. So that in and of itself does not really cause for harm. And even though there could be some cutting on areas of the body that often where people don't see. So I would want to assess, where on the body that person is cutting, for example, or even burning themselves, right? Because I want to understand the function of it and what their intention is with it, right? When they are cutting their wrists, say across the vein as opposed to in line with the vein, and those are two very different things, right? I would collaborate with that individual with some harm reduction strategies, right? If the method of their self-harm has the potential to be fatal or progress into something fatal, we would look at different options. We explore different options. But if the individual does continue with increasingly more lethal self-harm behaviors, then I would really think about speaking with the client about any sort of inpatient services, if that is something that they are open to, right? We would do a safety plan, right? And really reach out to their established supports, right? Because when we also think about intervention, we also want to encourage the support systems that are already present, right? We call those also natural supports. And, with releases of information, we do like to collaborate, within reason and with whatever is possible with those supports. But of course, if it gets to a point where the client does have active suicidal ideation, and they have a high level of intent, right? They have identified the means in which they want to carry out, and so on and so forth, then we would have to move towards more dire straits, unfortunately. Maybe dire is not the actually strike that. Dire is not the right term for that. But we would look towards hospitalization if the active threat is a high level of intent and they have a means of carrying it out. Again, because what it comes down to is we want to honor the life of the individual, right? That is part of our ethics, as part of our mandate, right? So I hope that did answer your question, but I would address the substance use first before really digging into self-harm and suicidal ideation.
We have one more, Dale. Do you think you have time for it right now, or would you like to get to it at the end?
Oh, let's get to it now.
Okay, great. Someone asked, what is the difference between active and passive SI?
Sure. The difference between active and passive SI. So someone with passive SI, this could be an individual, and actually in my own, with my own client caseload, I do have a number of clients who do express passive suicidality. That being, they have maybe just fleeting moments where they thought, maybe I would be better off just not on this planet. but they don't have an actual plan. They don't have a high level of intent. And usually when someone says that they have passive suicidality, and I continue to probe for that, I've asked the questions, what would happen to others what do you think would happen to others if you were gone? Who would miss you if you were gone? And usually, if they are able to name a number of people, and other reasons for why they want to live. Also, I would ask, on a scale of 1 to 10, with 1 being not at all, with 10 being very high, how ready are you to kill yourself today, right? And if they are passive, they may be between like a 0 to like a 1 to 2 or 3, right? When it becomes more active, the number would increase, and that is if the individual wants to share that with me, right? Because we know sometimes, not always, but sometimes, if a client or an individual makes a decision to take their life, they have a plan, they have a level of intent, they have a means. Sometimes they won't tell you, but what we can do as clinicians, if we have that access to them, is noticing a significant behavior change, right? Because if we've worked with them for any period of time, we're familiar with their affect, we're familiar with their moods, right? We're familiar with their mood swings, right? But when we see a dramatic shift in behavior, that also perks up my spidey sense, so to speak. Yeah, so someone can have, for example, daily passive suicidality, but we do want to monitor that, right? And I would want to also assess for what would have to happen in your life, for this passive suicidality to become active, right? We want to bring what is internal within the client or individual into the exterior, right? And, assessment for this is an ongoing thing, right? Any person that I know has a history of suicidal thoughts or suicidality, every time I meet with them, I am asking those questions. I am asking, how are you feeling about your life today? Do you want to kill yourself? How is your sleeping? How is your social interactions, if any, right? What are you enjoying today? What do you love about today? What do you like about today, right? And I'm finding that, and with those last 2 questions, I find that especially important, because it's okay. It's a lot of people say that they love certain things or love things about their lives, but I also want to ask, what do you like about your life, right? And even sometimes that can be a confrontational question, right? So it really depends on your therapeutic alliance with that individual, right? Assessing for suicide should never be comfortable, at least from my perspective, but it is necessary. It is very necessary. So yeah, that's how I would answer that question. Was that the last question?
We have another one that is, if they are drinking an extreme whereby they are shaking and it has consumed their being, how can one get to the inner part of them to help them with SI when they are in that very poor state? What would be the best way to speak to them in that state to help them see their substance use as being the main problem?
Sure. Yeah, that's also a great question. When I'm observing a client with those symptoms, my first thought is, can we get them to a medical detox, right? Because if they're experiencing shakes like that, and it's that, for lack of a better term, violent, it sounds like they're potentially going into withdrawal. And what we know from central nervous system depressants, such as alcohol and benzodiazepines, the withdrawals from that can be fatal, right? It's I believe like the only substances that you can, where the withdrawals can be fatal. So my first concern for that individual's safety is to really encourage them to go to detox, right? Because it's really difficult. I'm not saying it's impossible, but it is a challenge to break through the alcohol to speak to that person, right? Because they're so clouded by that substance, right? So my first thing is that I would want to encourage them to seek medical attention, specifically detox, so that way they can detox in a safe way, right? Because again, I'll speak for myself. It's really difficult to try to get through to someone and talk about suicidality when they're going through withdrawals. And of course, it's a case-by-case basis, and it depends on where you are at, right? Where your facility is, how close a hospital is. So long answer short, I would seek their medical attention for them first, so that way they can be safe and detox safely, and then we can talk more about suicidality. All right. Any other questions at this time? Okay, I will move on. All right, so moving on to awareness of risk and of shared risk and protective factors. Us practitioners must be aware that individuals who make a suicide attempt are at considerable risk for repeat attempts and eventual suicide, and that this risk may last many years. So folks who are at risk for suicide and substance misuse, they often share a number of risk factors that include depression, impulsivity, and thrill-seeking, life-threatening behaviors. And because risk and protective factors for the two can overlap, prevention professionals need to be aware of them and to implement prevention programming that reduces risk and enhances protective factors within the population and in communities. So let's go down the list of the dynamic and acute risk factors. So they can be, current suicidal ideation, current suicidal plan, preparation for suicide. Yeah, that was another thing that I wanted to mention in when we're talking about suicidal risk is when they start making preparations, right? Getting certain affairs in order, or tying up some loose ends in their life, right? That can be part of the preparation for suicide, and that can also be a sign for us to monitor. Acute symptoms of mental disorder, severe psychic anxiety, anxious ruminations, global insomnia, psychosis with delusions of poverty or doom, active or recent alcohol abuse. Then static and long-term risk factors. There could be family history, the Caucasian race, unmarried status, living alone, lack of social support, medical illness, unemployment, or even underemployment, a fall in social or economic status, rejection by spouse or their partner, previous suicide attempts, and the anniversary of important losses. And let's go into some protective factors. These can include a trusting relationship with a counselor, physician, or other service provider, An optimistic or positive outlook, child rearing responsibilities, coping and problem solving skills, cultural and religious beliefs that discourage suicide, employment, involvement with community activities, perceiving that there are clear reasons to live, right? Receiving effective mental and or substance use disorder treatment or care. Resiliency, we always want to promote resiliency in our clients, every single one of them, right? Self-esteem, direction, perseverance, sobriety, or wherever they are on their harm reduction path. Strong family bonds, and that does not necessarily have to mean biological family. It can also include family of choice and social skills. Okay? And this is not an exhaustive list of protective factors, but these are some really good ones for us to encourage and recognize in clients. Now, I had to throw in this cuteness pause here because, in my opinion, these are the two most important beings that you'll see in your life today. These are my two French bulldogs. On the left is Oscar, he's 3 years old, and Zoe, who is 6. Right? So I just had to throw that in there because they're very important individuals. So, and with that, this will be a good time for us to take a 5-minute break.
Okay, everyone, so we will plan to meet back at exactly 10:57 to give everyone a full 5-minute break. See you all back in a few moments. Hey everyone, and welcome back to today's webinar. Dale, if you are ready, I will pass the presentation back over to you.
All right, everybody, welcome back. So normally this would be a time where I would ask if there are any other questions before we move on.
Yes, Dale, there are a few more questions in the chat. Would you like me to read a few or would?
Oh, sure, go ahead.
Okay, great. We have someone that asks, what are the requirements for the Marchman Act, and do all counties have facilities that accept individuals with no insurance?
So what are the requirements for the Marchman Act? Is that correct?
Yes, that is correct.
So actually, I actually have never heard of that. Is that something that is specific to, is that regional? Is that something specific to Florida?
I am not sure, Dale, so I will just go on to the next question.
Yeah, sorry about
And
that. Yeah, I've never heard about that.
no problem. We can just go on to the next question. So we have another question that says, what does it look like to implement prevention programming that reduces risk and enhances protective factors within the population and the communities?
Sure. Yeah, that is a great question, and that actually is going to be part of the second half of the presentation. So I would actually encourage that this participant to hold on to that question and see if the following slides will be able to answer that. And towards the end, we can certainly re-round if there are additional questions of that. How does that sound?
Excellent. In that case, we are good to go on the chat. Thank you, Dale.
Wonderful. Thank you. All right. So why focus on the substance misuse and suicide interconnection? I'm so glad you asked. So behavioral treatment and prevention professionals like us have that unique advantage of being in a position to promote a public health approach, supporting preventative interventions across the entire continuum from prevention to treatment to recovery supports. Now, focusing on alcohol consumption, population-based studies have begun to show that alcohol prevention is suicide prevention. For example, in a study from Ontario, Canada, it revealed that as alcohol consumption in population rises, the suicide rate also rises by between 11 to 39%, suggesting that the population's level of alcohol use may be correlated with the suicide rate. And of course, as we know, alcohol is widely used. It's definitely a part of our culture. It's definitely, for lack of a better term, normalized in our culture, right? So alcohol use, as it will continue to be monetized, it's going to remain a high correlation with suicidality. So the public health approach to prevention. The public health approach to preventing suicide and substance misuse includes universal, selective, and indicated strategies. What follows are some suggestions that behavioral health, behavioral treatment, and prevention policymakers may implement to further promote this public health approach. So problem definition and gap analysis. First, you need to determine the extent of the problem. Estimating the incidence of substance misuse and suicidal behaviors is a precursor to developing a strategy to reduce suicides linked to substance use. So hopefully with the first half of this presentation, we're able to give you a good indicator, specifically in Florida, of the research, of the correlation, and why this continues to be a significant public health problem. Next, identify substance misuse and suicide prevention efforts identified that are already occurring, right? So similar to when we encourage individuals to use their natural supports, we want to identify what is already currently available before we start creating new avenues, right? So an environmental scan for existing substance misuse and suicide prevention programs is the next step in developing a strategic plan to address the intersection between substance misuse and suicide. Now, this environmental scan should include assessing programs in clinical and community settings, including hospitals, primary care clinics, behavioral health settings, crisis intervention programs, the criminal and juvenile justice systems. Let's put an asterisk on that because we know how punishing those can be. Schools, college campuses, community-based organizations, workplace, and faith-based organizations, right? So with any type of program development, we really want to focus on what is already there, right? Or program expansion, we want to understand what's already there so that way we're not, we're always going to be doing more work, a lot of work in any sort of program or policy development, but we do want to see what's already there that can help aid us in these efforts, right? And that's where collaboration comes in, right? This is where we begin the dialogue. Multidisciplinary collaboration is a very key attribute of public health. Therefore, that dialogue should emphasize a public health approach, and it should engage all facets of the community, that being the general public, elected officials, schools, parents, first responders, religious communities, and many others. And these should be launched and maintained. We want to translate the need for substance misuse and suicide prevention integration into distinct prevention funding initiatives. So funding exists for a wide range of community partners, depending on your community, of course. These partners are hopefully collectively form a natural constituency for integrated funding initiatives. Policy. We want to develop, disseminate, and implement policies that support prevention of substance misuse and suicide. Another area of policy development is screening and assessment. Further prevention goals by developing and promoting universal screening and assessment tools for substance use disorders and suicide risk. And as it relates to Florida, you can seek guidance and direction from Florida's statewide Office for Suicide Prevention, Office of Substance Abuse and Mental Health, Florida Department of Children and Families, right? And that link is right there. So program development. Once information has been gathered about the prevalence of suicidal behaviors linked to substance use, notably alcohol, and available programs addressing these issues have been identified, then we want to select and implement evidence-based programs that meet the specific cultural, community, and developmental norms of the targeted population, right? So this is where we should be intentional about what we're utilizing and how that can impact the targeted population. So community interventions must be able to deliver and, to some extent, integrate screening, primary prevention, assessment, diagnostic, and treatment services. Now, we all know that there's often in the field of social work, there are barriers in organization, right? Or I should say organizational barriers. And organizational barriers to collaborating may exist due to agencies' unique and distinct mission and the structures in place for addressing its mission. And using an interagency approach to develop a comprehensive suicide prevention strategy, state and tribal governments can bridge organizational barriers, build connections among agencies, and facilitate collaboration. Funding barriers. Funding mechanisms are another potential barrier to collaboration. Federal funding, which includes block grants for both mental health and substance misuse, and Partners for Success grants for substance misuse prevention, among others, is typically dispersed to a specific state agency or tribal government, which then provides subgrants to community agencies or organizations, institutions of higher education, and tribal organizations. These funding streams may reinforce each agency's unique way of operating and fulfilling its mission. Formation of suicide prevention councils, coalitions, or work groups that bring together stakeholders across agencies and organizations can help to coordinate funding from different sources and promote collaboration to tackle suicide prevention strategies. Philosophical differences. Now, previously, and who knows, this may be prevalent in certain communities or agencies, substance misuse preventionists thought of suicide as a primarily mental health issue that was best addressed through clinical interventions, especially for depression. Those working in the substance misuse field left suicide prevention mainly to mental health professionals. At the same time, mental health professionals were not always trained to work with suicidal patients or persons who had co-occurring mental and substance use problems. So working collaboratively across the mental health and substance misuse fields is therefore key to reducing suicide rates. Now, I can say for myself, working in a substance use program in Chicago, we can't divorce mental health and substance use, right? Even though we are a substance use program, we absolutely address the mental health because from our philosophy, those two correlate, right? But at the same time, there are a number of mental health, clinicians who don't have a lot of significant substance use experience, and while there's an understanding to that, it really is important to have at least a working knowledge of substance use disorders, or at least, be able to identify, withdrawal symptoms, risk factors, what it means when multiple substances or polysubstance use is active, right? It is important for all of us to have a working knowledge. Even if substance use isn't our primary focus, it is important because substance use is something that is normalized in our society, especially alcohol use and growing, and of course, marijuana use that's growing. So it is important that we understand those gaps in knowledge and seek to fill those gaps. And that actually goes well into the next slide, which is the lack of information. But this is more on a across agency spectrum. So reluctance to work collaboratively across agencies, departments, organizations, and professions may also be due to lack of information about the link between substance use and suicidal behavior. Prevention professionals should be informed about the connections between suicide and substance use, particularly underage alcohol use, binge drinking, and adult alcohol misuse, and be encouraged to work together on prevention strategies. I do want to highlight here, about underage alcohol use, because we know, at least a lot of us know that the adolescent's brain typically continues to develop until around age 24 or 25. But that is also potentially without any substance use. So when you do, when an adolescent does engage in substance use, and particularly significant substance use, that also impacts their brain development, right? And I'll speak for myself. When I was a teenager, what I thought were problems were astronomical. They were insurmountable. Everything is dramatic. Everything was extreme. Everything was awful. And I couldn't imagine how that would have even more exacerbated if I engaged in, underage alcohol use. And I imagine what that's like. I can only imagine what that's like for those who are underage, who are simply dealing with life, right? And all the emotions and all the anxieties that come with it, and then including alcohol use and how that can be exacerbated. So here are some actions for prevention professionals. So what should substance misuse prevention professionals do? Learn who is responsible for suicide prevention in your state or tribal organization. Become familiar with suicide prevention plans, strategies, and programs. Identify public health goals that you have in common with agencies, organizations, and/or coalitions leading suicide prevention efforts. Leverage each other's strengths and ask to partner with suicide prevention agencies and coalitions. Plan and implement cross-training on the link between substance misuse and suicidality and the risk factors and warning signs for substance misuse. Then use process and outcome data to evaluate and make the case that prevention works. Use data to show that reducing substance misuse lowers suicidal behavior and suicidal attempts. So this last part speaks to that earlier question when a participant asked about, assessing for or dealing with suicidality when there is, active substance use. So this sort of speaks to that with reducing substance misuse lowers suicidality and suicide attempts. It may not completely eradicate it, but research has shown that it does lower the frequency or the severity of the suicidal behavior or suicide attempts. Okay. What should suicide prevention professionals do? Learn who is responsible for substance misuse prevention in your state or tribal organization. Become familiar with substance misuse prevention plans, strategies, and programs. Identify public health goals that you have in common with agencies, organizations, and/or coalitions leading substance misuse prevention efforts. Leverage each other's strengths and ask to partner with substance misuse prevention agencies and coalitions. Plan and implement cross-training on the link between suicidality and substance misuse, the different types of suicidal thoughts and behaviors, and the risk factors and warning signs for suicide. Use process and outcome data from your substance misuse prevention colleagues to evaluate and make the case that substance misuse prevention is suicide prevention. Suicide prevention programs that address substance misuse help to lower suicide rates. So I hope, at least with these last two slides, you're getting a clearer vision of what we're trying to communicate in this PowerPoint. So I do want to take this time to go to the chat. Our lovely Cynthia posted some facts in the chat. Okay, so the scope of the problem. Suicide is a serious global health issue and one of the biggest preventable causes of death in the United States, according to the World Health Organization, the WHO, not the band, but World Health Organization. Close to 800,000 people commit suicide each year around the world, that was mentioned earlier. Globally, there is approximately 1 death every 40 seconds from suicide. In the United States, there are more than 47,000 deaths due to suicide in 2017. Suicide is the second leading cause of death for people between the ages of 10 and 34, and the fourth leading cause of death for those between the ages of 35 and 54. So let's get into more clinical interventions. Pharmacological interventions. So there are many FDA-approved medications for treatment of depression, and primarily among them are the selective serotonin reuptake inhibitors, otherwise known as SSRIs. As yet, however, there are no FDA-approved medications specifically indicated for suicidal ideation, urges, or behavior. So hopefully that's a yet. A few pharmacotherapies have been approved for the treatment of alcohol misuse. This may be familiar to some of you. They include disulfiram, if I'm pronouncing that correctly, which produces adverse symptoms following alcohol intake. Acamprosate, thought to mitigate withdrawal-related symptoms. L-naltrexone, a non-selective opiate receptor antagonist that reduces alcohol cravings. These drugs primarily operate by targeting reinforcement mechanisms involved in alcohol misuse. However, extended release naltrexone has also shown more benefits in reducing attendant anxiety and depressive symptoms. And of course, naltrexone is also known as Vivitrol. So SSRIs consistently produce a modest 15 to 28% reduction in alcohol consumption. However, intra-individual reductions in alcohol intake range widely from 10 to 70%, right? So it still is, the range is wild there because there's still a lot of research that still needs to be done on this, right? In addition to SSRIs, tricyclic antidepressants are thought to mitigate depression-like alcohol withdrawal symptoms and may be effective for co-occurring depression and alcohol use disorder. Antidepressants may not be justified for treatment of alcohol misuse in the absence of major depressive disorder, MDD. To date, however, there are insufficient trials comparing one medication to another, and few that examine the effects of pharmacotherapy on suicidality in alcohol users. Moving into psychotherapeutic interventions. These are some of my favorite types of interventions since I'm not a doctor, nor do I play one on TV. Brief interventions for suicidal crises, that being the safety planning intervention, SPI, can be often implemented in healthcare settings, typically involve a written compilation of suicidal thoughts and behaviors, triggers, coping strategies, and sources of support. Similar variations may include a risk assessment component, for example, EDSAFE, or the intermittent outreach, SPI. These interventions have shown success in reducing imminent suicide risk and may be potentially adapted to address simultaneous risk of alcohol misuse. However, like a lot of things, there is a dearth of research evaluating their effectiveness in co-occurring suicidality and alcohol use disorder. Motivational enhancement therapy, MET, is a time-limited intervention that utilizes motivational integrating principles to resolve ambivalence about treatment engagement and clarify goals related to alcohol use. And cognitive behavioral therapy for co-occurring mood and alcohol use disorder focuses on dysfunctional, distorted, or self-defeating schemas or beliefs that may be contributing jointly or severely, to depressed mood, suicidality, and alcohol misuse. So MI and CBT interventions have shown the greatest success among psychotherapeutic interventions used in populations with co-occurring alcohol misuse and depression and or anxiety, even in brief interventions, and longer-term treatments produce still better outcomes. And Cynthia also contributed into the chat more context with psychotherapeutic interventions. So thank you very much for that, Cynthia. Other interventions, such as relapse prevention therapy, RPT, and contingency management, CM, directly target the psychological reinforcement mechanisms that maintain addictive behavior. While they have been effective in populations with AUD and SUDs, there is still limited evidence of their utility in co-occurring suicidality and depression and alcohol misuse. Psychotherapy in combination with psychopharmacological treatment may also benefit from the advantages of each of these modalities, right? Right, clinical practice and research implications. So assessments of the role of acute use of alcohol in suicide attempts should begin with establishing if AUA occurred and estimating the amount of alcohol consumed. Assessments may include determining an individual's motivation for drinking before the attempt and a collaborative chain analysis with the individual. Chain analysis, if anyone hasn't heard about that, is a retrospective method for determining the sequence of events, thoughts, for example, suicide, premeditation, and drinking motivations, and behaviors, drinking, that led up to the suicidal act. Chain analysis, or otherwise known as behavior chain, is often used in substance use therapy or relapse prevention therapy. So if you haven't heard about these and have not seen any examples of these, I encourage you. They are wonderful tools and wonderful visual tools also. So the information learned from a chain analysis can be used to develop a personalized distress safety plan that highlights high-risk periods and warning signs, and to devise strategies for avoiding alcohol. Overall, the goal of the plan is to prevent escalation of suicidal risk in the context of acute use of alcohol. Future research directions include the study of real-time interventions via mobile applications, which could potentially coach individuals on adaptive strategies for suicidal thoughts, urges to drink, or distressing experiences. So as you can see, there are a lot of, there's a lot of room to grow with research. So this actually brings us to our conclusion. So further empirical research is necessary to differentiate the acute effects of alcohol intake on suicidality, separate from chronic or dependent use. Additionally, the gaps in intervention research on co-occurring suicidality and AUD are substantial, and pharmacological studies do not frequently account for the effects of suicidality, specifically in addition to mood improvements in alcohol users. Given the high prevalence of alcohol use alongside escalating rates of suicide, there is a compelling need for attention to their co-occurrence. All right, so with that, do we have any questions? So we're a little early, but are there any questions?
I do see one question, Dale, and that is, can a connection between substance misuse and suicide be attributed to both being considered coping mechanisms for dealing with pain?
Ooh, that's a very good question. Um, you know, what, how can I say this? Yeah, so in the work that we do, I'll speak for myself. In the work that I do, I acknowledge that a number of coping mechanisms, including, self-harm, um, substance use, or any kind of behaviors, were designed or implemented because they wanted to cope with life. That was a coping skill for them, and that may have been successful for them. So I do want to honor that and acknowledge that initially. Um, with suicidality or suicide attempts, I don't know if I would think of it as that. Well, that could be a method for that person to cope, but we also, as clinicians in the helping profession, we want to preserve life. We seek to preserve life, right? So we try to find alternatives for coping. And granted, a person can drink alcohol, socially. We know this, and we don't want to take that away from someone. However, if it is contributing to an increase in suicidality, and where they become a significant harm to themselves, if they are in our care, we have a legal and ethic and moral responsibility to be as present for that and intervene as seen necessary. So yes, we do want to acknowledge that a lot of these behaviors were coping strategies, at some point. Though it takes the collaboration of us and the clients or the individuals to figure out, is that negatively impacting their life, right? Because a person can engage in self-harm behaviors that are non-lethal, that do provide a source of relief for that person. And as long as we're continuing to monitor it, right? And assessing for any potential increase in fatality, we want to be able to hold space for that as well. Oh, and I see a new question in the chat. How does holding someone in medical setting to lower the BAC impact the suicide risk? So based on the research, and it's actually also hinted at in this PowerPoint, is that when you decrease, when you're holding in the setting, when you're holding someone in medical detox or the hospital to lower their BAC, the lower the BAC, the less the intense and the less severe the suicidal behavior may become, right? Because we want the alcohol to metabolize, right? And then to decrease that urgency to want to act on the suicidality. Let's see. Are there any other questions?
Hey, Dale, we have one more question from the chat, and that is, do you have any inspirational stories or anything towards, that you've been successful with in terms of actually implementing this that you could share with us?
Sure. Yeah. In my previous agency, I worked for Haymarket Center, and I worked in, different residential programs or units and in outpatient during that time as a counselor, but also working in management. That's where I really honed my skills in assessing for suicidality, because as a early clinician, I was very afraid of, or I had a lot of fear and anxiety about asking about suicide, because my misconception was, if I ask about suicidality, that will increase their desire for suicidality, and that's not necessarily true, right? So getting more comfortable with myself in asking those questions, despite how uncomfortable it is, I have been able to, utilize risk assessments, and even informal risk assessments. It's not like I always pull out a standardized form and ask these questions. I got more familiar with, tapping into the natural therapeutic alliance I had with these individuals, right? And I utilized that to learn more about the clients and be able to ask these questions and be able to have them trust me, that I won't, commit them, just by simply talking about suicidality. I encouraged and I embraced the therapeutic relationship. And that's always very important. Even if you're meeting someone for the first time and they're expressing acts of suicidality, you have that moment to build a therapeutic relationship, right? And a lot of times individuals want to be heard, right? They want to be validated. And starting with validation and acknowledging the resiliency that is already within them, whether they want to think it is or not, they all have resilience. And what I love about being a therapist and a clinician is not that I empower clients, because I know this is a term that a lot of people use, or a phrase a lot of people use, but for me, to say that I empower a client makes it seem to me that I have the power to give them that and I have the power to take it away. I truly believe that there is a power already within clients. And what I do is I help clients to see the power that's already within them. And you do that by the therapeutic relationship. You do that by validating them. You do that by reflection, right? Making sure that they're understood. Because again, a lot of them want to be heard, right? Because a lot of folks in their lives potentially maybe invalidated them, or they dismissed them, right? For any number of reasons. And what we hope to do is instill hope. And I've been able to do that, hopefully. I mean, I can't take full credit for that, but I have seen progression in some of the individuals that have been on my caseload or I've been in contact with, that I hope truly benefited from that therapeutic alliance. So, but yeah, that's how I have been able in the past to help clients work through their suicidal thoughts, is through the therapeutic alliance. Okay, let's see. I see other questions coming in.
We do have a few more questions coming in, Dale. We have a person that asks, how would you work with a client who is resistant to detox, hospitalization, inpatient level of care? For example, the client is incapable of outpatient level of care and multiple interventions have already been attempted.
Sure. And that is a concern that does come up a lot, definitely a lot, because of a number of factors. So if an individual is resistant, to detox, residential, whatnot, one of the things I would do is, as I've said before, I would help them to identify their supports that are already in place, right? And I would discuss harm reduction strategies, right? Because not everybody is able or wants to go into detox, residential, outpatient, for a number of reasons, because of desire to not want to be part of those systems. They may have work or family obligations, right? So on and so forth. And that comes up a lot, especially at my current agency. So what I would do is think about ways that we can reduce the harm. For example, let's say for example, they drink hard liquor. I would explore with them, what would it be like to consider maybe switching to beer or switching to wine? Or if they don't want to switch to beer or wine, what if we look at the frequency of their alcohol use? What would it mean instead of 6 to 7 mixed drinks a night? What do you think it would be to have 4 mixed drinks? And steadily and very, very steadily titrate down. Because we want to, if they're not willing to go to detox or seek any kind of medical attention, we don't want to ask them or encourage them to go cold turkey, because then they can plummet right into withdrawal. And as we discussed earlier, alcohol withdrawals can be incredibly dangerous, even fatal. So yeah, so I would parcel different ways we can reduce the harm by either slowly decreasing the amount of substances or the amount of alcohol, or switch to a lesser form of alcohol, or less severe form of alcohol, or any other ways that we can reduce the harm and help to stabilize. So that is where I would address with those individuals.
And the questions keep coming, Dale. Great presentation. We have another person that says, what is the best way to deal with a client who, sorry, the chat keeps moving up on me as I'm trying to read the question. They said, how do you deal with someone who is intentionally trying to drink themselves to death? What criteria do you consider? And they've like made it known that that is what they are trying to do.
Yes. So, so if a client makes that active threat to drink themselves to death, for me, that would potentially, I would seek supervision on this, of course. You know, I would talk with my supervisor and see if that actually does fit the criteria of wanting to consider involuntary hospitalization. I don't always like to do that, but if the client has a high level of intent, you know, they voice that they are trying to drink themselves to death, right? And they have a very high level of intent, I would do it on a scale of 1 to 10. And obviously they have the means of getting it, the alcohol. I think that would lead towards a discussion of involuntary hospitalization. Because especially if this is something that is voiced to me, I do have the legal and ethical responsibility to act on that. And what's the next question we have?
The next question is, what is your belief? How do you feel about sobriety if a person's drug of choice was crack cocaine, but feels they can drink alcohol? How do you approach that topic with the individual?
Sure. So how do I feel if someone's drug of choice, substance of choice is crack cocaine, and they want to drink alcohol? Did I understand that correctly?
Yes, that is correct.
Sure. So I operate from a harm reduction philosophy. I've mentioned that before, and that was in my bio. So I would like to know first, what is their relationship to the crack cocaine? You know, what is their experience of the crack cocaine? And you know, how does that work in the context of their life? You know, I always want clients to be able to live a life that is meaningful to them, whatever that looks like, because that looks differently for everyone. So if someone is coming to my office, and particularly a substance use program, willingly, and they say that crack cocaine is their drug of choice, and you know, but they also want to explore alcohol use, I would like to know, you know, again, what is the function of those substances in their lives? Is the use of those substances preventing them from what they would consider, quote unquote, normal functioning, right? And is it negatively impacting their lives? And we would like to explore that, right? You know, I wouldn't equivocally say that, no, you shouldn't do crack cocaine, because it's not my philosophy. And it's also not part of my agency. So understanding the function of it and how that works in their lives, and what they want from their lives in relation to their substance use. And how can we be supportive while also encouraging a life that is meaningful to them, right? So, so there's a number of different ways that I would do it, but since I do take a client-centered approach, that's what I would do. You know, some agencies have an abstinence-only philosophy, and there's certainly a place for that too. So you would have your own other types of approaches and strategies, right? You know, in abstinence only facilities, you know, 12-step philosophy tends to be very prevalent, right? But again, it all comes down to what does the client want to do? And are you able to provide those services that are aligned with your agency's mission and focus, right? Yeah, so I hope that answered that question.
Well, thank you, Dale. You're getting a lot of great feedback in the chat about how great of the presentation this was. Would you like to go through your resource slides before we conclude today?
Absolutely. All right, so first I did want to say thank you. I, of course, had to give a little bit more of Oscar and Zoe because, of course, they're so adorable. All right, so here are some of the references that I used for this presentation. And of course, here is the resource slide, you know, the Behavioral Health Treatment Services Locator, CDC, the Florida Certification Board, which offers free online courses available for CEUs, the suicide deaths, the Florida Health Charts, and from the Florida Department of Health, suicide use and prevention, the Florida Department of Children and Families, another resource, suicide prevention hotlines, the National Suicide Prevention Lifeline. The Veterans Crisis Line is available as well. And with that, I believe that's all we have for today.
Well, thank you so much, Dale. We really appreciate all of the work that you've put into today's webinar. It has been wonderful and great and very informative. And everyone, I'd like to do a couple of items of business before we conclude today. Please see the chat panel for a link to today's evaluation. You will be taken to our website where you will need to log in or create an account before you can take the evaluation. For CEs to be reported to CE broker for Florida licensed healthcare practitioners, please provide an accurate Florida Department of Health license prefix and number when you register. After you have registered or sign in, like I said before, you will be directed onward to the evaluation. You will need to make sure that you use the same email address you used when registering for today's webinar through our WebEx link that when you set up in your profile. This system helps connect your attendance with your profile. You will get a second opportunity to complete the evaluation through a follow-up email later today. The sender will be messenger@webex.com. Evaluations will close at midnight on Wednesday, February 16th. Please note that we do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile 30 business days after this event. Thank you for participating in today's webinar. We'd like to recognize and especially thank the Florida Department of Children and Families Office of Substance Abuse and Mental Health for funding today's education. Thank you all and have a great rest of your Thursday. Thank you, Dale.
Thank you very much.